Your heart monitor is showing a perfect rhythm. The transport aid is telling you to pack your bag and leave the room. You immediately assume your oxygen levels fell, or the clinical team is moving you to a higher level of care. But the doctor did not order this move. The building did. And the real reason has nothing to do with your medical chart and everything to do with the industrial machine you are currently sleeping inside. If you want to know the difference between a medical emergency and a plumbing schedule before you are the one sitting in the hallway, subscribe so we can keep translating these hidden hospital rules for you. When the walls of your room change without a clinical explanation, the anxiety is immediate and heavy. Patients frequently reported deep confusion and fear when moved for what the staff vaguely calls plumbing or maintenance. Because the hospital staff uses soft phrases like facility needs or deep clean to avoid discussing technical infrastructure or waterborne pathogens, patients often assume their room was contaminated with a deadly superbug. They assume they themselves are highly infectious. You sit in the hallway in your gown, feeling entirely depersonalized, wondering what your body did wrong to end up waiting outside your own door. Families of patients moved to specialized rooms describe a distinct emotional drop when they arrive and see the physical environment change, suddenly realizing the hospital has classified their loved one in a way they were not prepared for. Patients on telemetry express deep frustration at being moved multiple times because the machines keep losing signal, feeling like they are in the way of the building's Wi-Fi infrastructure. The reality is that your sudden room change has absolutely no connection to your chart. The hospital operates as an industrial machine with plumbing, ventilation, and wiring that constantly requires maintenance, and you are simply housed inside it. Take the oxygen and medical air running directly into your wall. The National Fire Protection Association requires hospital medical gas systems to be divided into discrete zones with isolation valves. When facilities management must perform maintenance, testing, or repair on a specific zone valve, all patients in that physical zone must be relocated regardless of their clinical condition. This creates a massive domino effect across the building. If your floor has 20 patients and 5 require continuous oxygen, those 5 must be moved to the next floor. If that floor is at capacity, 5 stable patients on that floor are shifted down to make room. The initial patient experiences a sudden, unexplained move simply because of a plumbing maintenance schedule 3 floors away. Your lungs are fine, a plumber just needs to turn a valve. The staff does not explain the code to you, they just hand you your belongings and point you toward the elevator. Then there is the air you are breathing and the water you are washing with. The American Society of Heating, Refrigerating, and Air Conditioning Engineers dictates strict ventilation rates for healthcare facilities. If the air handling unit serving your specific wing fails, or if its HEPA filters require scheduled replacement, your room legally loses its compliance for patient occupancy. The law requires a minimum of 6 air changes per hour for general patient rooms, and up to 12 for airborne infection isolation rooms. If an equipment malfunction drops the air changes below that legal threshold, the room is immediately condemned for patient use until it is repaired. You are moved to maintain the required airflow, particularly to protect your lungs if you are immunocompromised or recovering from a respiratory issue. The staff will not explain the ventilation standards to you. They will simply tell you that you need to change rooms for your safety. The exact same physical plant logic applies to the plumbing. The same engineering standards mandate Legionella water management programs. When a hospital initiates mitigation protocols, such as superheating the water in a specific plumbing loop or hyperchlorinating a wing's water lines, the tap water in those rooms becomes temporarily unsafe for bathing, brushing teeth, or drinking. Patients in that plumbing zone are relocated for up to 48 hours until the water tests clear. The staff will not tell you they are flushing the pipes for Legionella. They will just tell you the room needs maintenance, leaving you to wonder if the water itself is the threat or if your room was contaminated by the previous patient. Sometimes the move is driven by radiation or Wi-Fi signals. Infection prevention protocols utilizing ultraviolet. Disinfection robots require the absolute evacuation of humans from the space. This is a hazardous material evacuation. The robot shoots UV radiation into the room to eliminate residual spores from a previous occupant. The cycle takes 15 to 30 minutes, and during this window, the room and a 10-foot radius in the adjacent hallway must be completely evacuated because the radiation causes immediate damage to skin and eyes. You are wheeled into the hallway and banned from your own room because of a radiation hazard. The staff simply states they need to run a cleaning cycle, leaving you confused about why you are temporarily exiled from your own bed. You sit in the hallway chair, watching the door stay closed, entirely unaware that a machine is blasting ultraviolet light inside to kill spores left by the previous patient. Alternatively, if you are on a cardiac monitor, modern patient rooms are mapped for Wi-Fi and telemetry signal strength. If you are placed in a room where the Wi-Fi access point experiences interference, perhaps from a newly installed lead-lined wall for a nearby X-ray room or heavy structural concrete, the telemetry signal drops. Biomedical engineering flags the room as a dead zone, and you are moved to a room with verified signal strength so the central monitor does not lose your heart rhythm data. You feel like you're in the way of the building's network, treated like a data point disrupting the hospital's infrastructure rather than a patient receiving care. The reality is that the building's physical structure is blocking the Wi-Fi access point, and the hospital must move you to maintain the digital tether to your heart. Here is where the system disappears from your view entirely. When you are moved for a medical reason, it is documented in your electronic health record. When you are moved for a building reason, it goes into an entirely different software system called the Computerized Maintenance Management System. This enterprise software tracks physical plant work orders, preventative maintenance, and engineering assets. It is completely separate from your medical chart. Your doctor looks at the electronic health record to see your blood pressure. The facilities manager looks at the maintenance system to see if the air handler is due for a filter change. If a water line drops, a medical gas valve fails, or the HVAC breaks, the hospital files an Environment of Care incident report with their risk management department. This is a specific internal document triggered by physical plant failures. Unlike clinical patient safety reviews, which are often shielded from legal discovery to protect peer review, these facility maintenance reports are generally discoverable in litigation. They relate to premises liability and physical plant upkeep, independent of clinical judgment. The hospital is required to keep these physical plant logs, like HVAC filter changes and medical gas tests, for a minimum of 3 years under Joint Commission standards and up to 7 years depending on state-specific physical plant laws. But the log of which bed you were actually assigned to, the bed bore history, is typically purged from the bed management system 1 year after you go home. It is a quiet irony that the hospital will keep the maintenance log for a broken valve for 7 years, but will delete the record of which bed you slept in after just 12 months. The physical rules governing your room also change depending on the state you are in. In California, the Department of Healthcare Access and Information enforces strict seismic and structural standards. During non-structural retrofitting, like securing ceiling grids or anchoring heavy equipment, patients in the affected zone must be moved. In New York, health regulations require specific natural light and window operational standards. If a window is broken, sealed, or blocked by exterior construction like scaffolding, the room legally cannot be occupied until the natural light provision is restored. An urban hospital might move you to an interior room because exterior facade repair requires scaffolding that blocks your window, and you assume you are being downgraded to a worse room, completely unaware it is a legal compliance move regarding state building codes for natural light and fresh air. In Texas, the Health Commission dictates specific minimum square footage for patient rooms and bathrooms. If a hospital unit is reconfigured to meet updated state licensing dimensions for room size or accessibility, you are shifted to comply with the law, independent of your clinical need. There is one final physical room change that carries a heavy emotional weight for the family. When a patient exhibits severe agitation, delirium, or substance withdrawal, the clinical team may initiate a silent protocol to move them to a ligature-resistant room. These rooms feature breakaway door hinges, shower heads, closet rods, and even toilet paper dispensers designed to detach under weight. Families often experience a distinct emotional drop when they arrive and see the breakaway doors, padded corners, and lack of fixtures. They suddenly realize the hospital has classified their loved one as a severe self-harm risk, often without the clinical team having had a prior, transparent conversation about the psychiatric evaluation. The move is executed rapidly and without explaining the psychiatric evaluation to the patient to avoid escalation or violating privacy regarding their mental health assessment. It is a physical safety protocol for wandering and fall risk, driven by sentinel event alerts on suicide prevention rather than a formal psychiatric diagnosis. but the visual reality of the room leaves no doubt about how the patient is being classified. Knowing the difference between a failing air handler and a failing heart rate keeps you informed about your physical surroundings, but evaluating your actual medical condition and adjusting your treatment plan is a decision that stays entirely between you and your own physician. The hospital keeps the maintenance logs for years, but the bed assignment history is deleted after 12 months. What remains completely unrecorded is the exact reasoning the transport aide was given when they walked into your room to move you.